Now coming on to the management. We have once we have diagnosed this, we have taken the history, done the examination, done the different tests, then we can go for the management of the cerebral palsy. So before we start management, we have to define certain goals. For example, what kind of whether there's any bony abnormality present or not, and what kind of muscular abnormalities, whether associated or not, whether there is any neurological chance of recovery or not. Now all this have to be first established, and then we have to set a goal for the what kind of treatment we need for this child. What kind? So coming to the bony deformities, this could be due to abnormal muscle pull, failure of the normal modeling and development. There may be a normal antiversion. Usually a female is in 10 to 15 degree of antiversion, but there in these children usually they have maybe female may be retroverted as well, may be associated with external tibial torsion, and if there's too much external tibial torsion we may have to go for some kind of osteotomy. There may be a persistent hip flexion contractures associated with either subluxed or dislocated hip joint. There may be acetabular dysplasias and subluxation of the hip joint, which may be we have to rule out whether there is associated DTH or not present with them. There may be patellofemoral pain due to patellofemoral arthritis, and the spine may be abnormal as well, leading to increased scoliosis or kyphosis of the spine joint. Usually the sensory examination, there is problem with stereognosis and upper limb disability, but main pathology lies in the motor system, and motor system is what is mostly affected. Coming to the management, before we start the management, we have to set the goal that what we expect this child to achieve by this time, and that is to ability to communicate and cope with activities. That is important. Independent mobility assessment, that will be our treatment would help the child to be independently mobilized, or will our treatment result in further deterioration of the child, that whether this child has a straight spine or not, a level pelvis, because if the pelvis is oblique or spine is scoliotic, the child will not be able to properly sit even in a wheelchair. So that is important. Then whether hips, knees and ankle, how much mobility and flexibility is present in that. All this has to be determined and communicated to the parents that what are we expecting in this child. It starts in some degree of deformity, as there is a lot of spasticity. So there are some amount of medical treatment which is available for spasticity of the muscles. These include anticonvulsants, benzodiazepines, trihexyphenidyl for dystonia. There may be analgesic medication, GABA agonist. Intrathecal baclofen can always be given as well, so that these muscle spasm can be corrected. But this is it does help to some degree, but sometimes we have to move to the next option because there is always associated contractures. Botulinum toxin is one option which can be given for the decrease the spasticity of the muscle. It's, as you know, it's a potent neurotoxin. It blocks acetylcholinesterase release, and usually injected in spastic or dystonic muscles for managing pain and spasm of the muscles. Other is selective dorsal rhizotomy. There may be increased firing from the spinal cord, therefore L1 to S2 division of the nerve roots is done so that the spasm of the muscles can be corrected. This reduces spasticity and rebalances muscle tone. That reduces input from the spindle cells featuring of the PVL on the imaging. What actually happens is that due to as it is an upper motor neuron lesion, because there is constant firing from the spine and leading to increased spastic paralysis. Once the rhizotomy is done, this settles down the tone from hypertonia and becomes normal tone. Although there is decrease in the tone, but as there was already high tone, therefore now the tone becomes a normal. Other management options include physical therapy is very much mainstay of the treatment as well, because usually if it's flexible contractures, they can be very helpful with the physiotherapy. This actually why they reduce problems from abnormal muscle tone, they reduce problems from muscle imbalance, and most helpful in the age of 7 to 8 years, because that is time usually the contractures have not become severe enough, and the maximum effect of the surgery post-operatively as well. Other options is positioning a splintage of the joint. That is like casting, immobilizing for some times, and then physiotherapy, then for again immobilizing and physiotherapy. Now this can be done, and sometimes it's helpful because the joints are flexible and they can be molded as adjustments to wheelchair, etc. The splints can prevent muscle contracture. They can hold the correct head correctable deformity as well. And usually this is called dynama lycra splinting, which can be done for the foot and ankles. Other option is manipulation serial casting. This is limited role, although, but sometimes this can also be achieved as well because cast has weight as well, and it's kind of a dynamic physiotherapeutic unit. It acts as so that the muscular contractures can be prevented. Usually, the lapse is frequent with these, therefore, positioning, physiotherapy, and splinting is the mainstay of the treatment. Coming to the operative treatment can range from simple contracture release to muscle lengthening to muscle shortening to different type of procedures because they usually all types of things can be present in different joints. These indications include spastic deformity. If it's a fixed deformity, that is now the contracture becomes fixed. Secondary complications such as bony defects, bed sores due to abnormality, which has may have be part of the problem for the child. Usually, there is weak muscles. Muscle lengthening and weakening surgery can be done at the same time. Sometimes initially done in different settings. There's improvement of mechanical limb alignment. Sometimes osteotomy has to be done as well. For example, there's increased tibal torsion, then that can be prevented by form of osteotomy. Then correction of the bony deformities may be required as well, like calcaneal lengthening, hip subluxation that has to be reduced as well. Therefore, different procedures can be done for different joints for to achieve different targets. There may be augmentation of tendon transfer as well because we simply bony procedures are not enough. Different tendons because which are not working has to be transferred to on the area. Those tendons which are working have to be transferred on those areas where the tendons are not working so that the synergistic action can be achieved, leading to more cosmetically pleasurable deformity. Now, this all includes under the heading of surgical intervention, and all a non-philosophy actually is usually associated with it. That we have to first standardize that whether our surgical intervention would help the patient or would result in further deterioration. So that is how the planning is done, and then whether all the correct contractures can be dealt in one setting or then can be really done in different settings, but we can do every joint at the same time. In this section, we have gone through how to manage the different problems of cerebral palsy. It always starts with the medical treatment so that the spasm of the muscles can be corrected. Then comes the mainstay of the treatment is the physiotherapy, which helps to decrease the muscle contracture over time and keeps the joint supple. If the joints are supple and flexible, then we can continue with physiotherapy and splintage. But if now the contractures have become severe enough, then we may have to go for the surgical intervention. Depending upon which joint is involved and what kind of, sometimes the osteotomy is required, sometimes bone lengthening procedure is required, sometimes only the contracture release and associated tendon transfer is required. That's all from this section. Thank you very much.